Okay, welcome everybody to Optometric Education Consultants National Webinar Series Tuesday night edition. Our special guest is one of the most renowned and accomplished optometrists ever, Dr. Paul Ajamian. He's board certified by the American Board of Optometry and is the co-founder and director of Omni Eye Services Atlanta, the nation's first optometric co-management center. He paved the way for how we all practice today. He's a graduate of the University of Vermont and New England College of Optometry, author of 2 textbooks, and editor of Review of Optometry's popular monthly column Clinical Quandaries. He's a past president and legislative chair of the Georgia Optometric Association, an extremely well-known and accomplished continuing education speaker, and served as general chair of the Education Committee for SECO International since 2002. In 2014, he received the AOA's highest honor, the Distinguished Service Award for Lifetime Achievement. In 2015, he was inducted into the National Optometry Hall of Fame. He was appointed to the Georgia State Board of Optometry by Governor Brian Kemp in June of 2021, where he serves as president. As I mentioned earlier, it was his selflessness, foresight, innovation that allows us all to practice the way we do. So we're very fortunate to know and have him. Paul, thanks so much for doing this. So please, Paul, take it away.
Joe, thank you for your kind words. And it's obviously been a team effort along the way, and we've built this profession into something very special. And one of my themes tonight is going to be to use those skills that we've worked so hard for, and specifically in the area of cataract co-management and glaucoma care. Cataract co-management is how our practice started back in the early 80s, when an OD would send a patient or their family to an ophthalmologist for cataract surgery. They'd often really never see that patient back again. Maybe the OD was bad-mouthed, maybe not. Maybe they got a turkey for Christmas, but they probably got called a turkey by the ophthalmologist. And so things have changed a lot with our co-management center and 12 like it around the country. And then just a movement of obviously therapeutic drugs, and now 15 or 16 states with lasers. We're on the move. We just need to use what we've gained and make sure we don't lose our skills. And so that's a lot of what this talk is about. So we'll go ahead and go to disclosures, which I have none. I'm not on the advisory board or payroll of any company. I am the president of the Georgia State Board of Optometry, as Joe mentioned. So we've got a polling question number 1, that will kick us off, and I'll read it. It's the most important factor that determines if a patient is ready for cataract surgery in the eyes of CMS, the Centers for Medicare and Medicaid Services, is either A, aided visual acuity, B, glare testing, C, lifestyle complaint, D, the density of the cataract, or E, a clean MAC OCT.
So that polling question is open, Paul. The answers are rolling in. We'll let it go another few seconds here to get some more people to weigh in. Joe, I'm assuming that there's probably no questions in the chat box.
No, there's no questions, but a lot of people are saying hello and where they're from. So out of curiosity, if anybody's inclined, put in the chat box. Where are you right now? Where are you attending from? What states?
So we've got Pennsylvania, Georgia, and Florida covered from our end. So there we go. All right, I think we're pretty good in here. I think we got a nice sampling, and I'm going to display, and people can still answer, then I'll close it. Paul, we have aided visual acuity as 42%. We've got glare testing at 8%, Lifestyle complaint 46 as your winner, just barely beating out A, aided visual acuity by 43%. And then density is 1% and clean MAC OCT 2%.
Good. No one fell for that E that I threw in at the last second. That's good. Well, great insight by our attendees tonight, because it really is sort of a combination of A, B, and C, but I would say that C is clearly the winner. When people come in, we want to be sure that they're complaining about something. Absolute visual acuity doesn't necessarily appear on the radar. We've had plenty of 20/20 cataracts with a lot of cortical spoking, but tons of glare, and they're seeing through those anterior and posterior spokes. Certain insurance companies require glare testing. I'm going to talk about that in a minute, in a very specific way. And so, and they actually want acuity to glare down to 20/50. And so there's different ways to do that, but I'd say that the 46% of you that chose C, congratulations. That's really the absolute correct answer. But then, glare testing and acuity play into it. Obviously, Pinhole will help us with any monocular diplopia complaints. I don't know about any of you, but today was cataract eval day for us at Omni, and the first patient I saw this morning, because we have new externs, one from Nova, Joe, your old stomping ground, and she was just watching me do a cat eval, and the patient first thing said, I'm seeing double. And I don't know about any of you, but when I hear that I'm seeing double, I start to panic. I'm usually pretty calm in clinic, but I try to talk people out of that. Like, you're not really seeing double, right? Maybe your eyes are itchy, or glare, but monocular diplopia is what this patient ended up having, with one eye covered and then the other. The monocular diplopia was still there, and I said, wow, I've dodged a bullet, because I just didn't feel like doing a binocular vision exam.
Paul, it does happen more than we think, because when I developed my first cataract, and it was in my early to mid 40s, not only did I have monocular diplopia, I had triplopia. I actually would look at the little lighted D on my dashboard. I would see it, and I see one ghosting above it and one ghosting to the right of it. So I actually had
Um,
triplopia.
yeah, it's pretty common, and luckily can be explained usually by a cataract or maybe a corneal issue. But so back to glare testing, there's a specific instrument called the BAT, the brightness acuity tester, that not a lot of people have, but practices like ours do. And specific insurance companies, Aetna's the one that comes to mind, immediately want to see the BAT setting on medium, not on low or high, on medium, and they want the acuity to drop to 20/50. We used to do room lights on. That's not as standardized, and so they kind of poo-poo that. But if the vision's 20/40 or better, you want to bat them down below 20/50. If that doesn't work, you can roll this instrument in. And I was going to ask Greg and Joe if they wanted to market this with me, and just shine this in the patient's eye, and typically the glare will drop below 20/50. But seriously, here's the Mentor brightness acuity tester that you can still get. It's a little Gansfeld bowl, and you can see the low, medium, and nuclear setting. We used to put it on high, and everybody would glare to 2200, but again, the insurance companies caught on to that. So some of them are very specific, and in insurance audits or prior authorization cases, they'll want to see that. So I wanted to just quickly go through some things that all of you know and deal with every day, but a history, of course, is important. This is a 72-year-old came to us recently with sudden, well, he said gradual vision loss, but he was really meaning sudden because 2 months ago he said everything was fine and problems driving, reading out of that eye. And this was the cataract, and he was hand motion. And so we checked pupils because we didn't know what was behind this. We had no view. We did a B scan ultrasound, which was fine. But another good polling question would have been, can a really dense, mature cataract cause an APD? And of course, the answer is no, never. If there is an APD, that tells you there's something going on behind this dense cortical cataract. Before you send these people out, of course, a conversation with them about various lens options, about their astigmatism, about the surgeon and the process are very important. I think it's important to send a letter, and not particularly this letter. This is one of our referral pads, and we encourage our ODs to fill it out, but you can see that this patient was we just got this. The patient was scheduled in June, and Dr. Woodard is the surgeon, and it's a cataval. And the detailed reason for the visit is a cataval. So, not detailed at all, and doesn't really tell us anything about the patient or whether they want they're okay wearing glasses after surgery. They want to be eyeglass free in the distance or at all distances. If they're monovision in their previous contact lens wear, tell us something about their personality. Are they type A? What's the deal with the patient? We don't know them. You do. And so to convey that to the surgeon is very important. This is sort of a little bit, this is more useful. This is from a former resident of ours. And you can see that aside from sending the whole EMR 3-page summary of the visit with refraction and everything, the plan is outstanding. I mean, patient educated on findings, discussed our RD, visually significant cataracts, referred to Omni for cataval, would like surgery as soon as possible, kidney problems, so don't take NSAIDs. Otherwise, no contraindications to surgery, and the patient will most likely go with a standard PCIOL. So there was a conversation that was had here that was excellent, and it really allowed us to just do our job and say, yep, we totally agree with Dr. Heron, and let's go forward with surgery. The patient is prepared. We're not surprising them with anything like, oh, you have 3 diopters of astigmatism. Did Dr. Smith tell you about the high degree of astigmatism and a toric lens that you can pay $2,700 for? And the patient gets very upset and says, why didn't they tell me about that stigmatism? I never heard of that. So the more you can tell people, even in a short time, I know you don't have an hour to spend with them. That's our job in counseling for cataract surgery. The better it is for everybody. Obviously, doing a slit lamp exam, dilated fundus exam, and we see a lot of surprises on cataract day. I tell my students it's one of the most interesting disease days because people come in with pressures of 15 and 0.9 cups that have been followed every year by their OD, not dilated. Just basing it on that magic number below 21 couldn't have glaucoma, right? And above 21 they do. We know that's far from the truth. 50% of people with open angle glaucoma have pressure less than 21, and Harry Quigley has taught us that for a number of years. Expect the unexpected, and you can see narrow angles, you can see uveitis, you can even see on cataval day people that have already had cataract surgery and think they're coming in to get the cataract removed again, and maybe that's a Yagaval. So just be thorough in your exam, and expect to see more than a cataract is my point. What else can be affecting the ocular surface that would change the final outcome and lead to a refractive surprise? Well, anything that affects the surface. MGD, we've all heard about this ad nauseum. I'm not going to spend a lot of time on it. Chalazion, pterygia, corneal dystrophies, map dot fingerprint, any, of course, undetected pre-op retinal condition is going to affect the outcome. And so those are things that you want to warn the surgeon about in a letter so that one, they know that you saw it, and two, the patient is aware and is not surprised. Well, nobody would send this, right, for cataract surgery. This is kind of a gross mucopurulent Neisseria case, but I use it to illustrate that if you're not going to send this, then why would you send this? And these cylindrical, the cylindrical blepharitis or collarettes, very pathognomonic of Demodex. I know that we've gone, I think, a little bit too far. I'd be interested in what Joe and Greg think in their clinical experience. Now that we have a drug for Demodex, it's like 90% of blepharitis is Demodex, and I don't believe that at all. But there are a percentage of blepharitis patients that obviously have Demodex, and it's important to identify them. What do you guys think about the Demodex thing?
Joe, you want to go? You want me to go?
You go first, Greg.
Okay, perfect. So yeah, Paul, I agree. You know, now that we have a drug, everything looks like Demodex. You got to look at that, eyelash closely there. I think a significant amount of them are. And then, treatment works great. I think, two ways you can look at it. If the patient is asymptomatic, they might be asymptomatic because they slowly simmered there. You might want to ask them a little bit more detailed questions. But if they're symptomatic, we definitely want to treat them. But there are definitely other causes of blepharitis out there that go beyond Demodex. So, that blepharitis is can be complicated, but I think you have a really good picture there of a classic Demodex with those collarettes, those waxy going all the way to the base of the lash, where that
Yeah,
Demodex mite is hanging out. Go ahead, Joe.
yeah, I agree. I mean, people who have itching, crusting, dryness, they're symptomatic, and if there's any degree of collarettes, I won't use just for meibomian gland disease, but I'll use it. There are sometimes people who have very light infestations and they are symptomatic. I'll treat them. Sometimes they have very heavy infestations and they're asymptomatic, and I will treat them. And sometimes it's mild and there's not really any symptoms. I kind of just look away and walk on by without making any issue of it. But I do love the medicine, and I also love the fully reimbursable and billable follow-ups that are always successful.
Well, great. And it all goes to preparing the eye before you send to the surgeon, trying to treat the ocular surface and the blepharitis. But very few people do it, and it's frustrating to us when we get a 4+ blepharitis of whatever kind, and we know that it's going to affect the outcomes. But are we going to say, well, I know you were sent for cataract surgery and you're struggling to see and drive at night in the rain and all that, but we've got to take a couple of months and clean your lids and lashes, and they're going to ask, well, why didn't my referring doctor do that? So try to clean up the lids before you send them. Obviously, blepharitis and chronic staph lead to chalazions that push on the cornea and give you false topographic and A-scan readings, which is going to lead to the wrong lens implant power being chosen. And then the cleanup crew. This is the Xdemvy we were talking about. Lid scrub pads, Sequa, Restasis, Xiidra, the prescription medications that I think are also very underutilized we're just drowning people in over-the-counter tears, and or we're not saying anything and they're going out and buying Visine still in this day and age. Speaking of Restasis, which I'm on, this was a major update that I just received yesterday that Allergan has lost like 3/4 of their sales force and their upper management. They were waiting for the approval of a dry eye drug that was turned down by the FDA for, I think, the third time, and I'm not sure the name of the drug. I meant to look that up. But it's really, with Lumigan coming off patent, Restasis is already generic, although I still get it in the Allergan brand form. Durista's in question. Really, it turns out that AbbVie, that bought Allergan in 2020 for a lot of money, bought it for the Botox, and they really don't care much about the ophthalmic division. So Allergan, that it was near and dear to a lot of us that are of this age group, is really kind of going down the drain. And my Allergan rep, who's been my rep for 15 years, has already jumped ship and has a job with Taya Pharmaceuticals that bought all the non-preserved drugs from Acorn. So just a little up to the minute factoid there. Here's some double pterygium that obviously, rather than sending this for cataract surgery, you need to send it to the corneal surgeon to take out the pterygia and get the cornea stabilized before you then send them back to the cataract surgeon. This is something I see a lot of. Joe and Greg, I'm sure you do too, but for the longest time, I'll admit, probably up until 10 or 15 years ago, I'd just call this corneal scarring. This is a 55-year-old with a foreign body sensation. He can't wear his contacts. His eyes are just always kind of bugging him, but you also see this exact same picture with no symptoms, and you see these whitish elevated islands on the cornea that I've come to recognize immediately as, rather than corneal scarring, calling it Saltzman's nodular degeneration. And so this is a video that I will speed up of a Saltzman's case that Dr. Woodard brought to the OR and did a superficial keratectomy, even though they were sent for cataract surgery, and you can see that they need it. He'll start with a Wex cell, and he'll actually kind of dissect around that Saltzman nodule of the picture that you saw in the previous slide. And we're going to speed up this 4-minute video pretty quickly. But if you ever tried to debride a cornea and you thought you were going to hurt the person, just remember this video. I mean, he's just wailing away on this cornea with a Wex cell and now a metal spatula, foreign body spud, and the patient will live through this procedure, trust me. So I know a lot of you have debrided, small abrasions, and maybe you're timid, maybe you're aggressive, and there's some bleeding here because this is an inflammatory event. Sometimes blood vessels are going out to the Saltzman lesions, but it doesn't matter. You just put a drop of phenylephrine in, and of course, this patient's under pretty heavy topical sedation, and they'll be hurting for a few days, but they'll be treated with a bandage lens, and it's probably going to be a 6-month recovery after this happens. So let's go to, he's isolated the area, and now he's going to actually, with forceps, he's going to actually pick off this Saltzman lesion, if you will, to try to smooth out the cornea. And this patient had 6 diopters of corneal cylinder, very irregular cylinder. And you can see he's grabbing hold of it, and a boink, he'll get it here in this next pass, I believe. And he's just going to kind of peel it off in a sheet. And then he'll work on the pieces surrounding it. There we go. And it will smooth out the cornea very, very nicely. I'll go ahead and debride it some more. Again, the cornea can really take a lot of blows, and so foreign bodies, debridement, you don't have to be too gentle. So that's
And
how
Paul,
we ended up. Yes, sir.
and Paul, the main reason you're doing that is to smooth out that cornea, right? So you can get a good cornea reading so that if you do, when you do cataract surgery, since the cornea is 70% power of the eye, you're going to get a really good calculation. So you're just cleaning, your first was talking about blepharitis, cleaning that up, get that ocular surface. But now we're talking about cleaning up this cornea so they can get a good reading for that implant. Is that correct?
Exactly. If we just took the topo and the Argos A scan readings the way this patient started with us, we'd put the wrong lens implant in for sure. So this is the patient on the left here before, and this is the patient after. You can see those islands are gone. And then let's look at the topo. This was the keratoscope before, and this is after 7 diopters a cylinder, and now we're down to a quarter diopter centrally, 0.25, with HIPAA apologies to Tim Whitson. Sorry, Tim. All right. So that's preparing for the cataract surgery before you send the patient out for evaluation. Now we're going to enter the cataract portal, which some of you have been to at Niagara Falls, just an amazing place. And looking at the cataract at the Horseshoe Falls from behind. And we're ready for polling question 2. What type of cataract causes significant vision loss with a myopic shift, anywhere from 2 to 10 diopters, I'll add, yet with a decent view of the fundus? Is that a posterior subcapsular cataract, an anterior cortical spoking situation, milky nuclear sclerosis, or a pulverulent cataract? I love that name. Go
Well,
ahead.
Paul, while Greg is launching that, I'm going to have a lot to add to this because I happen to know a lot about it personally. But there is a question that comes about. What do you think about cataract surgeons pushing upgraded implants to unknowing patients?
We're going to talk about panoptics and upgrades, but to unknowing patients, it's happening a lot. The place where it's happening a lot in Atlanta is with the light adjustable lens for $5,200, and people are being offered basically that as the first choice, the best choice if you want an improved lifestyle. And who wouldn't want an improved lifestyle? So you're like, I'm going to be a loser if I don't pay 10 grand for these light adjustable lenses. But a lot of, with declining cataract reimbursement, we had another 10% cut January 1st of this year. It's surgeons are making up their lost income by pushing premium lenses. And it's good to discuss those premium options with patients if they want to get rid of glasses for distance, or if they want to get rid of glasses for all distances. But like you say, sometimes it's being pushed on people that really don't even understand what they're getting.
All right, so your polling question I will display. We have PSC at 30%. We have anterior cortical spoking at 17. We have your winner as Milky NS, and your purulent cataract is at 3%.
Oh man, thought more people would get that. So what percent was Milky NS?
We got 52%.
Excellent. So we've gotten the word out. I first learned about this And at Bascom Palmer, when Dr. Norton, the chair of the department, called me in and said, "Oh, look at this, look at this." And these are people that are chased all over the planet with various specialists because, yeah, it looks like an early cataract, but the vision's 20/50. There are -6 induced myopia, and yet the view through that cataract is crystal clear. And so people think, well, it must be retina, it must be neuro. And I've seen people go to retina and then to neuro and then back to the OD and then finally to the cataract surgeon. Joe, this is the kind of cataract you had, isn't it? At a young age, it's common in young, it's asymmetric.
Yes. Yep, it happened my right eye first. My left eye came several years later. I was just slowly losing vision. And the problem was I was doing my own workup. You know, I was running fields on myself. The only thing I couldn't do is look in my own eye. My residents were refracting me every other day. It got to a point I shifted about 5 diopters, couldn't do better than 20/70, but I could pinhole down to a crisp 20/25. And yeah, if anybody were to Google right now, Google images milky nuclear sclerotic cataract, my eyeball will come up. It is like one of the top ones. I've seen my eye in other people's lectures. And
That's
Paul,
good.
when you talk about the neural op part, one of my former students, age 39, was being worked up for vision loss, painless progressive vision loss in one eye, and she had already had two MRIs, a cataract consult, which was dismissed as a cause. She went to a prominent neuro-ophthalmologist at a prestigious university who could find no answers and referred her to a more prominent neuro-ophthalmologist at a more prestigious university. And she called me and said, "Look, just come here. You got a cataract." And there it was, a cataract. And she
Mhm.
was, she was saddened by it. She was kind of, she was kind of upset. And I said, "Well, geez, they were looking for brain tumors and NMOSD and MOGAD on you, and they're doing everything. Would you rather have a brain tumor?"
Exactly. Yeah, it can puzzle even the best of clinicians. So but it's on everybody's radar. A lot of you got it, so that's great. And here's the brunescent cataract that's so typical of aging, but this is the early milky NS uh, patient, usually younger, usually asymmetric, not associated with systemic disease, not really associated with anything. And then you can see the milky NS on the bottom right that actually ended up causing the patient to shift from plano to -10. Just crazy. And the
I just
axial length, of course, is the same in both eyes.
I just had one I had one today. The refractive shift was only 1 diopter and it was not nearly as dense, but you can definitely see it was right in the nucleus and there was a difference between the two eyes. And I told her, so look, you need some time to adjust to this. I'll look at you in 6 months, but I said I can guarantee pretty much guarantee within 2 years. And she's only 60 or 61. I said, look, it's gonna be you're gonna be doing this within the next year or two.
They progress fairly quickly. Exactly.
Hey,
So I
Paul, let me
want to
make a
just,
comment here
yeah,
that on
please.
if you go back to that picture, those are great pictures. Go back to a comment you made earlier. You can see that when the patient is dilated. A lot of people don't dilate anymore. And that's why they go down that rabbit hole of going to retina, going to neuro. So, you start getting those little refract. I think we're getting away from dilation. You can see it there when you know what you're looking for, but you can see it because it's also dilated.
Yeah, we're definitely getting away from dilation. I had a cataract surgery patient 6:30 in the morning about 6 months ago, a little old lady. I went to dilate her because we're kind of rushing to get everybody over by 7:15 for a 7:45 start time. And I go to put the drops in and she puts her arm up like this and she blocks me. She says, "Aren't you going to map me?" And I said, "I'm going to slap you. I don't know about mapping you." She was trained by her OD that mapping was better than dilation. And when she heard that I was dilating her, even for cataracts, she didn't want it done. So we're doing a bad job as a profession training people, or a good job, however you look at it, training people that dilation bad, mapping good. And it's just amazing to me how many people go into ophthalmologist offices and never even ask if they're being dilated. They just assume they are. They go into OD offices. I don't want to be dilated. We'll get into more of that later. I want to talk about surgery. It really hasn't changed a whole lot. FAAO, of course, came in the early 80s, Charlie Kellman, and then nothing really happened until 2012 when the femto laser came along that improved on the FAAO technique and made it more elegant. And now the next biggest change in my mind is 3D surgery. And we incorporated this a year ago. And now instead of the surgeon looking down at a microscope, this is my surgeon, Lawrence Woodard. You can see he's not looking into the microscope or tilting his neck down. He's looking past the microscope at this 3D picture that allows him to see the cornea everywhere from the anterior surface of the cornea to the posterior capsule clearly in one beautiful depth of field 3D picture. And it's not only helping their necks ergonomically, but it's helping them to know exactly where they are and to do surgery more accurately. So this is the Ingenuity system from Alcon, and we were the first to incorporate it in Atlanta. And it's all this equipment's expensive, so you won't see it in a ton of practices. How many of us are sick of this slide? 10,000 people are boomers are reaching 65 every day, and it is a large demographic. They've got a lot of money and they're still very active. They're playing pickleball or riding or swimming or all the things I should be doing, but I'm not. And so those are people that are interested in some of these options. And one of them is femto laser assisted cataract surgery, or FLACS. People for years have been asking, are you going to do the surgery with the laser? And we'd kind of apologetically say, no, not with the laser, but we have something really, really good called the ultrasound. And now ultrasound, or FAAO, is not as elegant. If we had our choice and we didn't have to charge for laser, we'd do cataract surgery with the femto laser on everybody. But now it's, yeah, you can have it with the laser, but you have to have a little bit of cylinder. It has to be under 3/4 of a diopter, or you have to choose either a toric lens, a Vivity, or a Panoptix, or the Johnson & Johnson versions of those, if you want the laser assist. And why do I think laser is better? Well, the incision making is pretty standard, whether it's a diamond knife or whether it's a laser. But really where it's at is the capsulotomy, the capsulorhexis, and then breaking up the lens without using any ultrasound energy, which of course beats on the cornea and can affect short-term results. So this is the basically the setup that we see once the patient is docked with a contact lens. They're laying flat, and this is, you're going to see the purple up in the upper right, and the purple here is the capsulorhexis. There'll be a little progress bar that will fill in, and then this is the nucleus, the yellow, and the tech will adjust that. The surgeon will tell them drop this down a little bit and center it on the nucleus, and then ready to go, ready to step on the pedal. Reproducible incisions every time, all anterior segment OCT driven. Beautiful laser arcuate incisions, comparing that to manual arcuates that are still being done in some practices. You talk about a money grab, they're doing it on just about every patient that has any amount of cylinder, and they're charging 600 per eye. And this is just like RK, and you all know what happened to RK. We didn't know how deep we were going and what the effect was going to be. And that's the same with manual arcuate incisions. We haven't done them in years, but some practices are. So the laser makes these precise incisions, and you can even open them post-operatively. It isn't done a lot, but you can. There's the beautiful scored laser capsulotomy. You'll see that in the video. And the capsulotomy, the capsulorhexis size and location determines where that lens is going to sit. And if it's posterior to the assumed plane, a 21 diopter lens is only going to produce 20 diopters of correction. You're going to get a hyperopic surprise, and vice versa if it extends anterior to the presumed plane. So very, very important to have the right an accurate capsulorhexis. So here's a video. I'm sure all of you have seen this a zillion times, but it's always fun to watch. Adjusting the nucleus, you can see down here, the capsulorhexis in purple is already set. This is the matrix pattern, or this cube pattern that you see in yellow. And the actual thickness of the wound is accepted here. And then you're going to see the pedal. It's going to say laser ready, step on the pedal, and you're going to see the capsulorhexis being performed. See the progress bar in purple, capsulorhexis, then it defocuses, and now the yellow progress bar, it's chewing up or elegantly cutting up the nucleus into these beautiful little cubes. And then very quickly, see the 3 bars up here. You're going to see the arcuate cut right here, the primary incision here, and then the secondary incision here, and it's done in about 35 seconds. They get whisked off, undocked, and whisked off into the OR, and the cataract comes out. I'm not going to show another video, you'll know it, but look at how narrow the angle is here. And one of the treatments, permanent treatments, as you know, for narrow angle glaucoma, if it's caused by the cataract, is to actually go ahead and take out the cataract rather than do a PI and waste their time with that. So what you're left with, and I warn some people about it because they think it's horrible, you know that subconj hemorrhages are, they prompt calls in the middle of the night from people, even though they're not serious. So I warn them that the suction around the eye from the patient interface, it's called, the contact lens, during docking before a lens X can cause subconj hemorrhages in a ring like this, and it doesn't mean anything, and they'll go away in 5 or 6 days. So now they're whisked off into surgery room 1. He finishes the case in surgery 2. They prep this patient, then he comes in. There's the lens that's broken up into little pieces. He's going to go ahead and test the incisions. Going to fast forward through this. And the next thing you're going to do is he's going to go in with forceps, and he's going to pull the capsulorhexis piece that was beautifully scored. He's going to pull that out right now. You can see how nice that is in high definition. So that's gone. Now he has access to going in and basically vacuuming out what the laser broke up. Now you see the CDE number on the upper right, and I'm going to move Joe and Greg and I down a little bit. You can see that CDE number, if he steps on the FAAO pedal to use FAAO energy, which he still can if it's a very dense cataract, will go up. But you're going to see him vacuum out this entire nucleus, and that CDE CDE number doesn't change a bit, cumulative dispersed energy. You're going to see this IOP number at 75. That's just a relative number that doesn't mean the pressure is 75. But look at the vacuum number that goes up when he's stepping on the pedal. All he's doing is vacuuming out the nucleus that was broken up. Look at the CDE, it's staying at 0. So he's going to go ahead and with his left hand, just turn the nucleus around and feed it into the aspirator. And this all should take about 5 minutes total, maybe 6 minutes, including putting the lens in. And, you know, it's amazing that there are a number of surgeons still, even right out of training, that are doing, you know, bragging that they're doing 12 to 15-minute cataracts. And that's just, to me, unacceptable these days. I mean, maybe in their first year, but they need to get good and fast. And sometimes they do, and sometimes they don't. So he'll clean everything up here. And look at the CDE, 0 phaco energy. So who's a candidate for that laser procedure? Anyone that we do premium lenses on, astigmatism less than a diopter. Ideally, you'd love to do it on patients with gutata, Fuchs, mature cataracts, traumatic cataracts. Sometimes those are the people, unfortunately, that can least afford it. It's important to tell people that it's not covered. They'll say, but I've got AARP as my supplement. Well, that's great, but your supplement's not going to cover it. Nobody's going to cover it. The only people that have ever covered it, the Salvation Army, because they pay their employees next to nothing. And we just had a couple of VA cases where the VA is starting to pay in limited numbers for the femto laser. That just happened over the last 2 months. So I want to just quickly go over, I mentioned Argos that does the A-scan. This is state-of-the-art A-scan that's going to connect with, that does connect with the laser and with the surgery suite. We acquire an image and all that data gets fed into the laser and into the surgical microscope. The image-guided technology that helps us orient the toric lens, you can see here. Look at the 3 marks on the toric lens that's been put in, and the image guidance is telling the surgeon that this needs to be rotated clockwise a few degrees to line up with that heads-up display, versus the old days where you'd mark with this purple ink mark. And I actually, in this older video, I had my surgeon put the ink mark in and it kind of dissipated. And if we had lined it up based on that, we would have been off about 10, 15 degrees. And in a 2 or 3 diopter toric lens situation, that's going to be a disaster. And then the image guidance can also help us. It also help. I keep saying us. I've never set foot in the OR to do surgery. It helps the surgeon center the Vivity or the PanOptix lens so that the center button is dead center in the preoperative pupil. And then this other incredible technology that we're using with most of our all of our premium patients and our LASIK patients that will pay an extra $500 if they will. Most of them do. It's called Aura. And Aura is actually like the final judge. All the pre-op scans are the jury, and the final judge is Aura. Aura does 100 readings. It measures front and back topography. It does an intraoperative refraction and aberrometry, and it tells us what the final lens choice should be. Coming in 2027, and we're getting the first instrument as a beta test site later this year, is this Argos that's fully integrated with topography MAC OCT and autorefraction. It's going to do all that in about 10 seconds with just the patient putting their chin in the rest, and the instrument comes to them. No longer will the technician have to struggle to get the patient to blink and get the right readings. This is going to be an incredible suite of instruments called Unity that's going to tie everything together. This is what you'll see real time with the Aura and intraoperatively. So the cataract is out before the lens goes in. It's going to say rotate the lens clockwise or no rotation recommended. Or I know you had planned a toric lens. That's great, but do not do a toric. Abort the toric. And we'll give them their money back on the toric. And thank goodness we did, because they end up plano with no cylinder, thanks to Aura giving us that last minute information. So our philosophy is we want outcomes determined on the front end. You can also do it on the back end. And some of you probably work with surgeons that do the light adjustable lens, and I think there's very much a place for the LAL, especially in big LASIK practices. It is being aggressively pitched to non-LASIK patients, however, at least in our market. And remember, it's a monofocal lens, so you're paying $5,200 per eye in our market for a monofocal lens. Yes, it corrects up to 2 diopters a cylinder, but it does nothing for you at near. And again, it's being pushed as a lifestyle lens. And it takes a lot of post-op time. It takes an optometrist doing 2, 3, 4 refractions before the lock-in. We just don't have that kind of time, and so we haven't gotten involved with this technology, but I'm sure it's something that some of you are involved with. So bottom line, Joe and Greg, we have to be involved in the decision preoperatively as referring doctors. It all starts with the patient's goals, their past history. Were they monovision? Do they care about getting rid of their distance prescription or their RX completely? Any comments or other thoughts while I get a quick glass of water?
Yeah, I agree, Paul. I agree. We need to be a part. I guess a blessing and a curse that is in our area is that if I send someone for cataract surgery, it's probably a 2 or 3 month wait, and it's probably maybe a 6 week after they see the surgeon. So the nice thing about that is we're able to clean up those lids, get that, that meibomian gland working, making sure that cornea keratitis is cleared up, especially, if that macula is healthy, and they want to get the best, kind of corneal refractive or type of refractive outcome from cataract surgery. Obviously, if they have macular degeneration, it's not as critical. We're not going to be doing their specialty IOLs, but I agree. We need just kind of a long way to echo. Like, we need to be a part, get that cornea healed, get that dry eye fixed, get those lids cleaned up. Because I echo back, I always say, Joe's heard me say it, and I stole the line from him, first grade of optometry school, but we were taught in the first grade of optometry school that our eye is 60 diopters, that cornea is 44. So if you put 40 over 60, that's 2 over 3, that's 66 to 70% of the eye power comes from the cornea. So that cornea needs to be healthy. And this was just a good way of saying we participate and need to do that.
Yeah, we do a fair amount of light adjustable lenses in our practice. And mostly these are people who are post LASIK, PRK, post RK patients. So I think it kind of is legitimate. You're right. You're spending quite a bit, and it's a lot of effort. You're talking maybe 5 more visits. And the optometrists in our practice are the ones who are doing the adjustments. I don't do it. My wife doesn't do it. We don't have an interest in doing it, but there is a need to have the ODs do it. It's a lot of work. And talk about cleaning everything up. Yeah, there are surgeons that will, they'll go right in and just do the cataract surgery. I know we have 3 corneal specialists. And if you send a patient to one of them and the patient has basement membrane dystrophy, well, now that patient is looking probably at an SK first in one eye and then an SK in the second eye. So it turns out that, getting cataract surgery can take nearly a year.
Exactly.
But,
Superficial
but they do it,
keratectomy.
they do it because they believe it and they want the best possible outcome. And I certainly agree, but you, you've got to know your surgeon and prep the patient, for that. And the ultimate it usually comes out pretty well. But I can't think of a single SK patient that I have had that has come back and said, gosh darn it, I am so happy I did that.
Right.
Because
Yeah, for
it was
map dot
uncomfortable.
is that's a little aggressive, but
Mhm.
yeah, I mean I think that part of what you're saying also is that uh in this title of our role is crucial, how do we know what their philosophy is and what they really do? And the way to determine that is to go invite yourself to a half a day of surgery with them and see what their temperament is in the OR and see what their philosophy is on uh, pre-op selection and post-op care. It just goes a long way to helping you describe to the patient what they're going to experience. And so, get a VIP in your practice or a family member or someone that needs surgery and accompany them. It means a lot to the patient, and the surgeons can't disguise their behavior in the OR. So if they're going to be bad babies, I call it, and they're going to pitch a fit, they're going to pitch it whether you're there or not, and even when you're there. And so I just think it's nice to know what you're dealing with. And so bottom line is that it's just really embarrassing if they hear things from the surgeon for the first time. So a couple of weeks ago, we had a patient with 3 diopters of cylinder, and it was what was called what we do is called same day surgery, where to save them a trip, we're doing the exam and the surgery in the same morning. And I went into the discussion about astigmatism and then told him the price and that he was a good candidate. And he just went crazy, not only on me, but especially on the OD. Why wasn't I prepared for that? Why? And a lot of ODs don't have topographers. And I'm going to encourage all of you on the webinar, if you don't, to think about that as a purchase this year, because it's really hard to prepare patients for cataract surgery and give them any kind of meaningful education if you don't know what's on the cornea. And the refraction is part of it. Ks are part of it, but topography really helps you determine if it's regular, irregular, if it's that beautiful bow tie, 3 diopters or 5 diopters. That's going to tell you that they need a toric lens and they can't have a panoptics or Vivity because those only correct up to 2¼ diopters a cylinder. So speaking of premium lenses, I think that's a good segue into this.
Actually,
And
Paul, before you go on, a couple of questions
sure.
came in. Will Argos 2027 help with our RK patients' cataract surgery? Because right now they're recommending the light adjustable lens.
So what helps us, not being an LAL practice, is the answer is yes, it will help with RK patients on the front end. And part of that is aura that I described. Again, I think that LAL has a significant role if the practice has the manpower, OD power to see the patients postoperatively I think LAL is a good option. But what the Argos Unity does in 2027 is it basically incorporates other instrumentation into the A scan. In one fell swoop, you'll have your A scan, your topography, your MAC OCT, and your refraction. And it's just going to be much easier for a practice like ours and much more accurate.
And one more question for people under an ERM peeling and vitrectomy, they usually get cataract. How long should a patient wait post-vitrectomy to get the cataract surgery? And are there more complications that in a person who just had a membrane peel and vitrectomy?
Well, great question. They'll need that patient will need to be on an NSAID 3 days before and a month after at least. And I think that's all going to be based on retinal clearance from the retinal doctor that did the surgery. So it's probably going to be at least 6 months, but you will need a clearance letter. The patient will need a clearance letter from the retinal doctor saying when it's appropriate to do that surgery, but probably 6 months to a year. Great
Excellent.
questions.
We're all good.
All right, so I mentioned toric lenses go up to just over 4 diopters. We did a patient the other day with 5 1/4, and between the lasers incisions, the LensX incisions, and the toric lens, we got all of the astigmatism. I saw the patient for the 1-day visit last week. And those are the little marks that I showed you when the surgeon was lining it up. The PanOptix trifocal, and we're an Alcon shop, so you wonder why am I not mentioning J&J lenses? We've used the Symphony lens, and now there's a new version of it. One of my surgeons is putting one in a couple of weeks. It's the refined version of the Symphony. But practices tend to either go all Alcon or all J&J because you get volume discounts. And but we're doing some more and more J&J lenses, which are good lenses. But the PanOptix is an Alcon lens that was released in 2019 to replace the Restore. And the PanOptix Pro was released last March. That was kind of a new and improved, a little bit less glare and rings and halos around lights and a little bit more light getting through with better intermediate. So we've been putting PanOptix Pro lenses in for over a year now. So we're on polling question 3. Which of the following are contraindications for a PanOptix lens? If a patient wants to get rid of glasses altogether, which of the following are contraindications? Irregular astigmatism, macular pucker, dry eye, is that a contraindication? LASIK history, or all of the above are contraindications? Lock in your answers.
Polling question is open and answers are rolling in. Joe, are there any other questions or comments?
The chat box is now quiet.
We could turn this into the 1% Club. Anybody watching that game show? That's pretty cool. The 1% people that answer it correctly, but I think we'll have more than that on this one. So you really want to think twice before you recommend a PanOptix lens based on some of these factors here. And let's see what the audience says.
Yeah, I think we got the response. I think we got the trend in here. We've got A at 11% with irregular astigmatism, macular pucker 6%. No one went with dry eye, 0%. LASIK was 1%. And all the above was your winner at 82%.
Excellent. Good job, 82%ers. So yeah, all of these are relative contraindications. Irregular astigmatism definitely is. Macular pucker for sure. You could switch, and if the patient still wanted some intermediate vision, computer vision, You could switch to a Vivity, which acts more like a monofocal lens, but you've got to tell them that they're going to need readers for that close distance. But intermediate, it will grocery store shelves when they're doing their shopping, arm's length reading, computer. Vivity is a lens that you can put in anyone that you'd put a monofocal lens in. But Panoptics, you're going to pay the price if you recommend a Panoptics for someone with irregular astigmatism, any kind of retinal problem, severe advanced dry eye, and LASIK is an absolute no on the Panoptics lens. So great job. And this just kind of, you also mention, it mentions here, what about glaucoma? If it's, they've got 0.4 cups and they've got a little ocular hypertension and they're in their 70s, I wouldn't worry about the Panoptics. But if they've got any kind of moderate to advanced glaucoma, you're going to want to avoid the Panoptics. Everything needs to be perfect. But again, if they want some kind of near acuity, the Vivity is a good option. Let's talk about post-op care just for a little bit. And, this is something that is obviously near and dear to my heart, because I remember when we started the practice, we would write 4 $25 checks and we'd mail it to the ODs, $25 per visit for post-op care. We put on post-op cataract workshops. ODs were not involved at all, and we got them involved. Now, post-op management of regular lenses, premium lenses, light adjustable is mostly done by the surgeon until they're locked in, or the surgeon's practice. But I think it's important to be involved if you can. I understand that a lot of people are in practice situations now, unfortunately, where only vision insurance is covered, and so anything medical is not. And to file the 54 and the 55 modifier that's endorsed and really initiated by CMS in 1986 during the Medicare Inclusion Act for optometry. Basically, if you can only do vision care and file vision insurance, you're not going to want to see the post-ops for nothing. But there are a lot of private practices that are turning their backs on post-op care because, as you know, cataract reimbursement has declined from $2,200 when I started in the business down to about $500 now. And so that 20% is now about $80. And you've got to make that stretch over 3 visits. And to a lot of people, it just isn't worth it. And I respect that. However, we've got a lot of ODs that are not doing post-op care, that are making their patients drive, an hour each way to us for every post-op visit. If you are seeing them at day 1, a lot of people are dropping the 1-week visit and turning that into a 2 or 3 week visit if everything's going well on the day 1, if the pressure is normal, etc. But on day 1, depending on your surgeon, some surgeons have consistent corneal edema, and that's okay. It usually clears up. If it's significant edema, 2080, 2100, 2200, you'll want to put the patient on a steroid. Maybe they're already on a topical steroid. I don't know. We're a dropless practice. I'm going to talk about that in a minute. But be positive. Tell them it's just the first day and everything's going to be fine. And really, those 1-day visits are very quick. They're, how you doing? Good. Pupils probably still dilated. Check the vision, check the pressure, and look at the slit lamp and determine how much cell and flare, and you're done. I did. We're in between students, Joe, our Nova student, I told you just started, but we've got a group of students coming in next week or the week after. So I was grabbing post-op day 1 charts like it was going out of style today, and the average time I spent with all of them is 5 minutes. So pretty easy. So again, if you're not on Medicare or any other insurance other than vision, it's tough. Some people will tell me I'm not set up for it, and I don't know what that means. If you're not set up insurance-wise, I understand what it means, but otherwise I'm not set up for it. I don't know whether that means you don't have a slit lamp and a chair and stand, or I'm not sure.
It probably means they're not competent.
And some people are, yeah, some people aren't, but I hope we're beyond that, but you might be right. I just think about the trip times and keeping these long-time patients in your practice. They're very grateful to be able to get their care 5 or 10 minutes from their house instead of driving back and forth to the surgeon. And the other thing that happens to us, based on a lot of experiences, if we see them too many times for the post-op, and now I say, okay, now it's time to go back to Dr. Caldwell for glasses and your ongoing care, and they're like, Doctor who? You're my doctor now. And I know Greg's not at all forgettable, so they probably would never say that. But really, the more times they see the surgeon, the less likely, the less willing they're going to be to go back to the referring OD. So I mentioned
if they're not set up, Paul, it could be that they don't take medical insurance and they can't bill that other 20%.
right. And I totally understand that. I mean, you don't want to do it for free. Joe, what's your, I mean, we've noticed the trend that we used to see maybe 10% of our post-op patients and 90% went to the ODs, and it's flipped not quite on its head, but we're probably doing 70% of our own post-op care. What about in your practice? Because it's very similar to mine as far as referral.
We do a lot. We do most of our own care. Now we have a referral network, and it's pretty well understood by the patient care coordinators what ODs will see a 1-day post-op or a 1-week post-op or a 3-week post-op. So generally, I don't see those. The ones that I will see that may come in usually is I'm referring the patient to the surgeon and I'm getting the post-op. If a patient comes in of their own accord, not on a referral, but just by our practice reputation, I might see those patients in post-op, and they don't have an OD, and they will probably end up staying within our practice. But most of the patients I send over, I do all my own post-ops. We will do post-ops for community ODs depending on what their preferences are.
That sounds about right. So one of the things that we did back in 2015 to make it easier for the ODs that want to see their own post-ops is we got rid of drops. And dropless surgery has been incredible in our practice. A lot of practices have not embraced it because they have to pay for the medication, and we just bit the bullet, and we're happy to do that for patients, especially those who have challenges, not only physical, mental, arthritis, to squeeze the bottle. They have no family members to help them. They won't get the drops filled, or patients in nursing facilities that trying to transmit those instructions to the staff is very difficult. So what we did is we went to something called Trimoxy, which was triamcinolone and moxifloxacin, and it was this big white goober of medicine that sat in the vitreous. It was injected transzonularly and sat right on the visual axis, and people were blind for the first few days. And we got away with that for about 4 or 5 years, but ODs and patients alike, understandably, were kind of freaked out when the patient was hand motion at the first day, and they dilated the patient, saw this big white wall in front of them, and called us and said, The patient's had a retinal detachment. So we transitioned over the last 3 years into something called Dexmoxy, and that is an intracameral clear fluid drug injection into the anterior chamber of dexamethasone and moxifloxacin. The dexamethasone is not enough to last during the post-op period, so we give them a subconj Kenalog injection, and you can see that right here. And so we warn the patients that when they pull the lid down, they're going to see this little white patch for about 4 to 6 weeks. And if the patient is Caucasian, this combination is enough, like 99.9% of the time. In the African American and darkly pigmented population, if you don't supplement it with an NSAID like a Prolensa or a Bromfenac once a day for a month after the surgery, there's probably about a 30% rebound rate 2 weeks after they come in and they say, I woke up last night, my eye was beet red, light sensitive, and I'm miserable. I'm in pain. And you look in and they've got 2 to 3 plus cell and flare again, where it had quieted down before. So we prophylactically treat those folks with a topical NSAID. So any other cataract questions before I leave that and we transition over to glaucoma?
No questions.
Okay. Comments from the peanut gallery, Greg and Joe?
Nope. All
Okay.
good.
All right. So tied in with cataract surgery these days are glaucoma procedures, as all of you know. And there's been a term attached to it called interventional glaucoma that some people are embracing and some people are skeptical of, but we've gone in whole hog and we're very convinced that this is the future. So I want to go ahead and ask this question. Interventional glaucoma refers to sending patients to a specialist before they go blind. B, send the patient for a MIG in early to moderate stages of glaucoma. C, send the patient for a tube shunt or valve after demonstrating advanced cupping. And D, intervene with a third or fourth medication before they progress more. So let's go ahead and lock the machines.
Nothing is
question.
rolled in the chat box, so you're good there.
Polling questions open and answers are rolling in.
So this interventional glaucoma thing started with some of the devices that the company Glaukos makes. Glaukos has been a company that's been very supportive of optometry and optometric education and big meetings like SECO and AOA, etc. So let's see what people think.
So the answers have rolled in. I displayed the results, and we got 6% going with A, send patient to specialist before they go blind. Your winner at 77% is send patient for a MIGS in early to moderate stage. And then 12% was for shunt valve after demonstrating advanced cupping. And then 4% was with third or fourth med before they progress more. So your
Okay,
winner was B.
Nobody bit on those red herrings I threw in there. Good job, gang. Yeah, I mean, let me go into this and we'll learn a little bit about interventional glaucoma. So this is a case that my glaucoma specialist and my new staff OD love to present, so I stole it from them. This is a patient, John Smith, who has been managed by his local doctor for 7 years. And he was referred at that 7-year point to a glaucoma specialist for disease progression. By the way, in case I forget to mention it, there aren't a lot of glaucoma specialists to refer to anymore. It's really hard to find one. They want to do cataract surgery. The pure glaucoma specialists are, in our experience, few and far between. I took over the glaucoma practice in Atlanta for 3 years when our glaucoma doc left. And I met with several big practices, including Emory University. And I said, I'm going to send you my surgery, my SLTs, my early surgery, my late surgery. I would send them a patient on maximum meds that I inherited from our previous guy. And they would come back and say, yeah, we agree, advanced glaucoma, we've upped the alpha-GAN from BID to TID. It's like, that's just great. Like, I couldn't have done that. So there aren't a lot of aggressive people out there, especially you would think the university settings, the Bascom Palmers, the Emorys, they're just not embracing this like we think they would, like we thought they would. So anyway, this patient is referred currently on latanoprost and the dorzolamide timolol COSOP combination, and the pressure's 18 in both eyes. So let's take a look. 7 years ago, the pressure was 24, nasal steps in both eyes. Latanoprost was started. That's reasonable. Pressure decreased to 17 or 19. 5 years ago, so 2 years later, progression noted, timolol added. Pressure goes from 17, 19 down to 16. 2 years after that, after multiple visits in between, the pressure is ranging between 14 and 20. The patient admits that he forgets his drops occasionally. He has missed some appointments, which means he's definitely not using his drops. And then a year and a half after that, missed a few more visits. The field is still progressing, and the patient switched from timolol to COSOP. Pressure's 14. Now further progression at 14, ranging between 14 and 18, and finally referred to a glaucoma specialist 7 years later. So, I mean, the vision's still 20/20, but not for long. The limitations that are illustrated by this fairly typical case are that you can have disease progression, and you often do, despite multiple medications. And why is that? Non-compliance, non-adherence is probably a big reason. Aggressive disease, maybe less so. And undetected pressure spikes. Remember that a pressure that we take is only a moment in time. Speaking of pressure, I had 4 different post-op patients today who the tech ran an eye care tonometer on. I know that eye care is very popular now. It's easier than some previous handheld instruments like the TonoPen, etc. And it's much easier than training your techs to do Goldman tonometry, right? But Goldman is still the standard. One case particularly comes to mind from this morning, pressure of 29 in the post-op eye that was done yesterday. I did Goldman, it was 22. So you always want to check if the eye care pressure is up, you want to check it with Goldman. But what about in between the times that we're checking the pressures? I mean, what's happening at home? What's happening at night? What's happening in the days between the visits? And there's probably a lot of spiking going on, causing progression. So this traditional approach is when it gets so bad that you realize that, the 3 and 4 medications are not doing the trick, that's when you intervene and you send the patient to a glaucoma specialist for a tube shunt. We've just been programmed to use drops, and especially in optometry. But guess what? In 16 states, optometrists can do an SLT really early on. which is part of this whole interventional glaucoma thing. So we're still seeing, again, at major eye institutes, big practices, just piling one drop on top of another. And then you consider doing something else when maximum meds no longer control the pressure. So what are we learning? That these interventions, the SLT and the MIGs, work much better in the mild, especially mild, but to moderate stages, and are less effective in the moderate to advanced stages. And what's happening is over time, there's irreversible damage being done to the trabecular mesh. And no matter what you do at that point, you're not going to restore outflow. So you need viable tissue for these MIGs to work, and they're not going to work after a period of time. You do have an early window of opportunity. This is very, very important. So my bottom line has become refer earlier, but you can only refer earlier to someone who believes in this, not to someone who's just going to put them on another drop, which you could easily do yourself. Don't forget about, again, IOP fluctuations. I remember Tony Litwack, who's still out there on the lecture circuit. Tony talked about really kind of what Harry Quigley preached for a long time, that you want to get 3 different pressure readings on 3 different days before you establish a baseline and decide what you're actually treating. There's a lot of stuff happening at home that we don't know about. And so this eye care home tonometer is really something that's, even though it's got a high price to it, may be worth looking at for patients that you suspect are fluctuating. So the recommendations for these mild to moderates: get them on a drop. If that stabilizes them at your target pressure and they can tolerate the drops, then that's great. If not, get them out for interventional glaucoma evaluation, and then knowing that you're working with a surgeon that will get them back to you, and you'll have them for the rest of their life, but you won't have to work as hard at, again, worrying about compliance, forgetfulness, ocular surface disease, etc. I mean, this is a perfect example of a patient who was sent by Dr. Valley. He saw the patient after she was seen at Marietta Eye Clinic for 3 or 4 years by a glaucoma specialist. And this is what he described to me. This patient had significant pink eye in both eyes. Can anyone guess what drop she was on?
I'm going to say with that, Ropressa, but.
Exactly. Bingo. Ropressa is a decent drop, but it just beats the crap out of the eyes. And so not only the red eyes, but the cornea. And this was her corneal verticulata, or whatever you call it, that kind of almost mimics amiodarone keratitis. And this was after 3 years on Ropressa. So her problem was that everywhere she went, her friends said, "Are you okay? Are you sick? Or are you on drugs?" And she went back to the surgeon and said, I can't take this anymore. Everybody's asking me if I'm on drugs. And the MD said, "Well, I'll tell you what, the drop is working pretty well. So I will write you a letter stating that you're not on drugs." Honest to goodness. And so she wasn't happy with that. She went to John. John sent her to us. Speaking of marijuana, you all know that just last week, the DOJ and the DEA have officially moved marijuana from Schedule 1, which they should have done a long time ago, to a Schedule 3 controlled substance. So it's in there with Tylenol with codeine, rather than with morphine and LSD and fentanyl. So let's go to this last polling question, gentlemen. gentlemen meaning Greg and Joe, and ladies and gentlemen meaning the audience, what MIG might be a good choice for this particular patient with drop intolerance and moderate to advanced now feel loss, because she was just put on that drop and several others over a long period of time, and she has pretty significant feel loss at this point. A, iStent, B, iDose, C, SLT, D, CyPass. Go ahead
And
and
as
lock in.
Greg is launching that, Paul, a question came in. I'm not sure how deep you're going to go into this in the last 10 minutes, but it's being asked, are MIGs, or maybe we should say what MIGs are done without cataract surgery, not in conjunction with cataract surgery?
Excellent, excellent question. And the answer is the iStent Infinite, where you put 3 iStents in. You don't need to do it with cataract surgery. And the Omni trabeculectomy procedure. I'm going to go over that in just a couple minutes. So good segue. Any answers, Dr. Caldwell?
Yep, they have rolled in, and looks like the trend is set. iStent was 53%, iDose was 3%,
Wow.
SLT was 36%, and CyPass was 8%. So 53, 3, 36, 8.
Okay, so I don't think iStent is wrong, but the key to this question is moderate to advanced feel loss. The iStent is not going to lower pressure nearly what we need it to if we're going to get the patient off of drops. Let's drop down to D. The CyPass is no longer made, so that's not an option. That was a trick question. SLT is really good for early glaucoma. It doesn't work well in the later stages. I'm not saying that people aren't doing it, but it's not going to result in much more than a 2 or 3 millimeter drop. The thing that we've been relying on here is B, the iDose, and I'll tell you her story in just a second. So we recommended that she have cataract surgery because she did have cataracts. We stopped all her drops. We put an iDose in when it was first approved a year ago. And after 3 weeks, look at her eyes. So this is the before and this is after, much quieter, right? Her husband was not very impressed. He was asleep in the back here, but she was impressed. That's the important thing. So the iDose provides up to 3 years of continuous travotan. It costs just under $15,000. There's good Medicare coverage, but we're struggling on the commercial side. We're having to fight for every single one that we put in. And so, like I say, 3 years of medication in that tiny little bullet. And this is the procedure being done with this gonio lens. And this is a little bit of a herky-jerky video for some reason, but you can see that it takes literally about 15 seconds to inject it right into the trabecular meshwork. And then you can actually see this with the slit lamp without doing gonioscopy. You'll get the view of and there it is, and it'll sit there for 3 years. People ask what happens after 3 years? Well, guess what? The FDA just approved refueling it and being able to put in another one after 3 years. So there it is, the diagrammatic, and then you can see the slit lamp view where you're going to be able to see that iDose inserted. This patient was seen last month after a year. Her pressure's 10 on no medication. Just great results. So to answer the question, the great question that was asked, this is our menu now. We've just got all kinds of MIGs that we can do. I'm going to run through these quickly. The old iStent on the top picture, the iStent bullet. The iStent Infinite is just multiple iStents that can be put in separate from cataract surgery. That was approved as a standalone procedure in 2022. And I'm not going to get to all these videos, but you can see the iStent Infinites being put in here. And those will just stay and act as little snorkels. There's a third one being put in a couple clock hours away. And there they will sit, and you'll see them when you do gonio. The Hydrus is kind of a scaffolding kind of situation where it's got 4 openings, and it is inserted and threaded through the trabecular mesh. You can see here. Isn't that cool? And the Hydrus is used for more moderate to advanced cases versus the iStent, which is early to moderate. And then the Cahook goniotomy, where you're just basically slicing and dicing. You're just taking a hook and opening up the trabeculum. These are patients that you'll see at the 1 day or the 1 week, and they're going to have a little hyphema typically. You can see he's doing about 6 clock hours with the Cahook goniotomy. And then the Omni procedure is a standalone procedure, the trabeculectomy. And we're going to see it actually graphically here, where it's put into the trabecular mesh, and this little plastic tube is basically threaded through either 360 or all the way around. And the actual video of that is here.
So for the audience, what happens in glaucoma is the trabecular meshwork tissue is not the same as my tissue. I don't have glaucoma. It becomes oxidized. It becomes sticky. It's not, diabetic muscle is different than someone with that doesn't have diabetes, and I'm talking like physical muscle. So the trabecular meshwork becomes sticky, sticks to Schlem's canal, and clogs up those collector channels. So basically, what they're doing with this procedure is kind of roto-rooting, going in through the trabecular meshwork, going behind the trabecular meshwork, separating it from the canal in the back, trying to open up those collector channels, just trying to free up and get that aqueous to be able to drain a little bit easier.
Excellent summary. So really, I think we should own the glaucoma space. As I mentioned, Joe, you may know this, but there's a practice on the other coast of Florida where the glaucoma specialist, who's well known, is charging patients that want to see him $3,500 a year as kind of a concierge fee in order to see him because the demand is so great. If we don't embrace glaucoma, I think PAs and nurse practitioners probably will. It's an interesting disease. Most people do well, and if you send them out early enough for some of these interventional procedures, they're going to lead a long, happy life with good vision and good visual fields. So just don't miss the diagnosis. I'm still, and I know Joe is involved with this too, seeing too many lawsuits of ODs that are just have that magic number locked in their head at 21. And if it's over 21, they panic and send them out. If it's under 21, they don't even look at the nerve, and people are slowly going blind from glaucoma. So this should be what, to us, what diabetes and hypertension is to the internal medicine doctor or PCP. We've got to get more involved in glaucoma care. We've worked, goodness knows, very hard to get these privileges. I'll get students asking me, when are you getting lasers in Georgia? And I'm like, why don't you get out and practice glaucoma care first, and then we can jump to lasers. So I hope this has been helpful, and kind of a whirlwind tour through my co-management world here. And I hope that some of the things I shared were useful. I know a lot of it's basic stuff, but just reminders. And thank you for your attention. I really appreciate it.
Hey, Paul, before we formally end, question came in. Anything in the horizon for glaucoma treatment besides lowering pressure?
Great question. You know, John Berdahl is working with intracranial pressure, and NASA and space, talking about the effect of increased intracranial pressure to counteract the intraocular pressure. We featured John at SECO about 5 years ago. I haven't really talked to him since then about where that's going. I haven't read a whole lot about it, but I think the only new thing that I know is what we've embraced is this interventional glaucoma, just getting them some of these procedures earlier on rather than, again, piling the drops on one after painful another, and knowing that patients just are not good compliers.
Yeah, they're still, or we're still searching for that holy grail of neuroprotection, and it's not there yet. And despite what anybody may think out there, please don't. Alpha again is not proven neuroprotection. We've not found that holy grail yet. Paul, I agree. We should be in the glaucoma space more, if not owning it. You know, things are changing. You mentioned nurse practitioners and PAs. You know, Paul, my dermatologist is a PA, is my dermatologist PA, and she's a fantastic young woman who the only difference between her and our dermatologist is Mohs procedure. She doesn't do Mohs. But there are places for us where we can help. You know, something besides glaucoma that I have embraced is the neuro-ophthalmology patient. So that's what I do because there's hardly any competition there.
Exactly. Good job.
So everyone, do you see that where it says survey right here? You can start that survey. We need that for the COPE and CE broker. We have to make sure we're closing those gaps. With that being said, so please do the survey there, or you can wait till 10 o'clock Eastern and you'll get it via the email. I will make a comment. Paul's talking about interventional glaucoma. I speak in that arena. Again, it's to decrease that burden of those drops that can beat up the ocular surface, create that neurotrophic keratitis. And also, whenever people do need to go for trabs and blebs and true surgical type of procedures after they go beyond the MIGS, we now know that those many years of that drop burden causes failure, scarring, fibroblasts. So even at the OGS meeting, the Optometric Glaucoma Society meeting, they talk about trying to get those SLTs done, trying to decrease that drop burden, using the thing like the iDose to be able to get 3 years. I've used it and we use it in the practice. I don't insert it, but I have a surgeon that does. What amazing results, and you get to see those nice low pressures. So it's also about that ocular surface, which you touched upon, but I just wanted to echo it. So, all right, Joe, are there any other questions?
Nope, there's just the virtual round of applause for Paul, thanking him for a great lecture. And I want to do the same, Paul. Thank you for a great lecture. Fantastic. Always great to hear hear from you, and virtually spend some time with you. I think the last time we were all together was in our meeting in Quebec City, and we had a great time with you up
That
there.
was an amazing meeting. Thank you both so much for everything you're doing in the education arena.